Great. Well, as we continue on, we are very, very pleased and very, very glad to have Professor Miguel Hernán with us today. He is the director of the Causal Lab and the Colocatrones Professor of Biostatistics and Epidemiology at the Harvard T.H. Chan School of Public Health. In addition to his really groundbreaking research, he also has a really wonderful textbook, Causal Inference, What If, that he's co-authored with Jamie Robbins, and is a book that I taught out of in the fall. And he has numerous awards and recognitions that would take the whole hour to kind of go through if we really had time. But just to name a few, he was elected a fellow of the ASA in 2019, and in 2022 he was awarded the Rousseau Prize for Statistics for his really groundbreaking work in causal inference. Today, Professor Miguel Hernán will be talking to us about some of the pitfalls of immortal time and the biases that are arise from those mistakes. So the talk of his title is Immortal Time and Other Misunderstandings in Causal Inference from Observational Data. So yeah, we're very glad to have you here today, and yeah, please feel free to start whenever you are ready.
Thank you very much, Samuel. That was a very kind interaction. I assume that you can hear me well? And therefore,
yep.
Great. Can you see my screen now? Perfect. Yeah, so I'm going to be talking about immortal time, as I said, which is usually described as a bias. I'm going to argue is more of a misunderstanding, something that should not happen, but happens because we don't adopt the right framework to think about causal inference. So immortal time bias is something that I'm sure most people here have heard about. It started to gain prominence in the late 60s, early 70s with the heart transplant studies. There were a number of observational studies to estimate the effect of heart transplant. And these studies found that heart transplant work, the people who conducted studies, they concluded that heart transplant worked very, very well because people who had heart transplant were less likely to die than people that didn't have a heart transplant. Of course, what happened here is that they were for only people who have survived for the time between they become eligible to get a heart transplant until the time that they actually got the heart transplant, there was an organ, heart, that was available for them. So those who have survived that period have this time during which they couldn't die, because otherwise they wouldn't have been in the heart transplant group. So that period within which they cannot die is the immortal time. And when you add that immortal time to the actual survival time after transplant, yeah, they have a longer survival than people who don't get a heart transplant and therefore don't have this immortal period. Then after that, there has been a lot of studies that have found similar benefits. For example, there are studies that say that corticosteroids are associated with 30% reduction in mortality, which is not possible. Beta blockers with 60%, statins with 70% lower risk of cancer. All these things are not correct. They are just the result of this problem. There is even this very famous paper that found that Oscar winners live longer than non-Oscar winners, which of course, again, to be an Oscar winner, you have to survive until that time. So you count you count that period until you get the Oscar. Yes, Oscar winners have a longer survival than non-Oscar winners, but who don't have necessarily, who haven't necessarily survived until that time. And there is the same thing has been said for jazz players and many other things. Now, this bias was described by Mitch Gale and NCI in the in the early 70s. He read the papers, the hard transplant papers, and saw very clearly what was going on, and has this beautiful paper in Annals of Internal Medicine that describes the bias. Jamie Robbins in the 80s developed a theory for causal inference that under which it is impossible that this bias happens. And Sammy Sousa, for a couple of decades, had been documented how this bias still happens. It's very, very common. Is probably the most common bias that goes through the editors and the reviewers of journals. And there is a lot of discussion about this, about how to name it, about what really is the problem, about how to analyze the data to prevent the immortal time. There are hundreds of papers about this. And many of these papers, they insist that this is a problem of misclassification of person time. I'll talk about that and explain why that's not really the problem. Now, what I plan to do is to provide a framework to think about immortal time bias. And this framework is based on the concept of the target trial. We will be talking about the concepts of eligibility for the target trial, treatment assignment to a target trial, and time zero, or the start or follow-up. And I'll be describing two types of immortal time. One is the result of selection, and the other one is the result of misclassification. And the fact that there are different reasons why we have immortal time is actually, it explains a lot of the debates and the discussion about this concept. So by using the target trial approach and explicitly defining what is the reason for the immortal time, what we will do is during this talk is to unify the literature. We will present a unified view of the literature on immortal time. Also, part of the problem is that even though some of us have already explained immortal time in these terms, there was there are very few attempts at providing a causal graph that describes what the bias is. So, in fact, we did this in 2019. We have these talks and these presentations where we proposed causal graphs, causal DAGs for immortal time, and we were going to publish them in 2020, but something happened that year that got us a little bit distracted. We started working on other problems. So now I think we are ready to present this whole framework. And as I said, we will go over the two types of immortal time, about the causal graphs for each of them, and more importantly, we'll talk about how to make sure that this never happens to you, that in your analysis you don't have immortal time. And the first thing that I will do is to talk about the target trial. And also, let me give you a spoiler for this whole talk, which is I'm going to conclude that really that immortal time bias doesn't exist. There are other biases that exist that are the reason why there is immortal time. So it's not that there is a bias caused by immortal time, but rather immortal time is the symptom of other biases. Okay, so let's talk about the target trial first. A brief introduction to this concept, because we are going to rely very heavily on it for the rest of it. This is all about causal inference from observational data, and of course, if we could, we would always make causal inferences based on randomized trials, but we can't. So that's not an option that is on the table, saying we'll never use observational data. There are too many questions for which we will have to use observational data, or else there's nothing else. So since we have to use observational data, even though it's not our preferred way of making causal inferences, what we can do is to think about each causal analysis with observational data, when we are using observational data for causal inference, we can think about what is the randomized trial that we would prefer. Rather than doing this, what is the randomized trial that we would like to conduct to answer this question? That hypothetical randomized trial is the target of our causal inference. That is what we would like to do. But because we cannot do that, we're using the observational data to emulate that target trial. And so the target trial is the hypothetical randomized trial that we would like to conduct to answer the causal question. We can think of the causal analysis of any of observational data as some attempt that we are making to emulate that target trial. If we emulate the target trial correctly, then we will have no bias, and if we don't, then we fail in the emulation, we will have bias. This actually, we can take this one step further, which is that if we are using observational data for causal inference and someone asks us, hey, what is your target trial? If we cannot define our target trial, chances are we are not asking a well-defined causal question. So this concept of a target trial has been present in the causal inference literature for a long time. The earliest reference to the idea that I have been able to find is by Dorn, a statistician at NIH in the 1950s, and he was talking about this idea of using observational data to emulate a randomized trial as closely as possible. He wasn't using the term target trial, but it was the same concept. And at the same time, Wald, who was an econometrician working in Sweden, was also using this same concept. And in the 60s, we have William Cochran at Harvard, and then Don Rubin, who was Cochran's graduate student and eventually chair of statistics at Harvard, was also very explicit about this idea. Also in the 70s, Feinstein, a clinical epidemiologist at Yale, and Phil David, a statistician in Cambridge, England, they were all talking about this concept of, okay, let's use the observational data to try to mimic a randomized experiment as closely as possible. But all these people were talking about this in relatively simple settings. They were considering treatments that happen at a single point in time. You are treated or you are not treated now. But many of the questions that we ask, if not most, of the questions are really not involving treatments that either happen or don't happen, but treatments that may evolve over time. We have time-varying treatments in a lot of the questions that we ask, because we're asking questions about not about point interventions. We're asking questions very often about strategies, treatment strategies that are sustained over a period of time. And it was Jamie Robbins in the 80s, as I said, that developed a theory of causal inference that incorporated time-varying treatment. So this is the general theory of causal inference based on counterfactuals and sustained treatment strategies that we use now and that most people use now. So this is the general version of target trial emulation. And the idea is then that causal inference needs to be seen as a process with two steps. The first step is we have to ask the causal question. The second step is that we have to answer the causal question. And this is probably the most important slide of the talk. There are really two steps. We don't have data and start analyzing it and fit in a Cox model or this or the other way. First, need to say what our causal question is. Then we try to answer that question. And a very natural way of specifying our causal question is specifying the protocol of the target trial. If we can describe the target trial that we want to emulate, then we are articulating our causal question in a sufficiently well-defined way. Once we have the protocol of the target trial, then we have two options. One is we conduct the trial if we can, and if we can't, then we use the observational data to emulate it. And then we can talk about statistics, but not until we have articulated our causal estimate, until we have the target trial. Then we can talk about the estimators. Some of the problems, and the case of Immortal time is a very good example. Some of the problems in causal inference are that the causal estimate, the protocol of the target trial, was not well defined. So causal inference from observational data starts by designing a randomized trial, even though we are not going to be able to conduct that trial. So when I'm talking about the protocol of the target trial and the specification of the protocol, I mean that we need to specify the basic elements of the protocol of the target trial, which are the same as the elements of the protocol of any randomized trial. We need to be able to describe the eligibility criteria, who is going to be in the trial, the treatment strategies that we're going to compare, the assignment, how people are going to be assigned, the start and end of the follow-up, the outcomes, the causal contrasts, is going to be intention to treat or the protocol, effects, and of course, the data analysis. And once we have this, everything here but the data analysis is what defines the causal estimate. Then we do the same. We use the observational data to emulate in an explicit way each of these components. Now, if we follow this process, we are going to achieve one main thing, which is that we're not going to have biases that are due to bad design. There are some biases, and the case of Immortal time is a good example that happens not because there is a bias in the data, but because the way we design our analysis creates the bias. I'm going to refer to that type of bias as a design biases. And design biases is what target trial emulation eliminates. What target trial elimination doesn't eliminate are the biases that are in the data, not the bias that we create, but the biases that are there, like confounding and measurement error. All those things, of course, we cannot eliminate magically by saying that we're going to emulate a target trial. But all these other things, as we will see now in the case of Immortal time, all these things that are biasing our effect estimates because we're doing something wrong with the data, that is what disappears when we use target trial emulation. So let's talk about the two types of Immortal time, and then you see a little bit more specifically what I mean here. Okay. So first, we can have Immortal time when we select people into our analysis using a criterion, using an eligibility criterion that happens after the start of follow-up. But we start the follow-up before that time, okay? Now, this could in principle happen in a randomized trial if some of the data have been deleted, as I'll explain now, but it typically happens in observational studies. So here, the problem is that the eligibility criteria are not aligned with the start of follow-up, because some of the eligibility criteria are happening after the start of follow-up. Let me give you an example. Let's say that we have a randomized trial, a very large one with 16 million people, and they are assigned to either treatment or not treatment. You start treatment at the time of randomization, that's going to be z equals 1, or do not start treatment, that's z equals 0. And let's keep it simple. This is a trial with full adherence and no losses to follow-up. So we have 8 million people in one arm and 8 million in the other arm. You see there that more people die in the first 3 months in the first arm than in the second arm, and then people keep dying after the first 3 months. And total, there are more deaths, twice as many deaths in the in the treatment arm compared with the no treatment arm. So if we were analyzing this data, we could compute the risk of death at 12 months, which would be 6 deaths out of 8 in one arm, and in the other arm is 3 deaths out of 8. That's a risk ratio of 2. The risk ratio is also 2 at 3 months based on the data that I gave you before. And the survivor curves could look something like what I showed there, with there is a lower survival for the Z1 for the treatment arm, not for the no treatment arm. So in this is how we would analyze the data from this simple trial. We have time 0 is the start of follow-up, is the time of randomization. We follow people from time 0, and everyone has to meet the eligibility criteria at time 0, and everyone is assigned to either Z1 or Z0 at time 0. So the eligibility and the assignment are synchronized at the start of follow-up. Okay, I mean, I hope this example is not insulting your intelligence. It's a very simple one, but now I'm going to complicate it a little bit, which is that, let's say that after conducting these trials, the investigators, by mistake, they deleted the first 3 months of data for every person in the trial. So they don't have now any information about what happens between month 0 and month 3. That means that anyone who died in the first 3 months disappears from the data. They don't have that person now. And therefore, they cannot construct the survivor curves that I just showed you. So what can they do? Well, let's consider 2 possible courses of action. Both of them are biased. One is if the investigators say, well, let's just continue as if nothing had happened, and just construct the survivor curves with the data that we have, starting at the time of assignment. And the second thing is, well, since we are missing the first 3 months of follow-up, let's start the survivor curves 3 months after assignment. So this shows the survivor curves if we have all the data, and this shows what happens if we proceed as if nothing had happened. If then, as you can see, because no one dies now in the first 3 months, because all those people have disappeared from the data set, then the survivor curves are flat between 0 and 3 months, and then they start to diverge. Of course, this is not going to give the right absolute risk or relative risk. The other option is, and this period between 0 and 3 months is an immortal time now, because no one can die by definition there. The other option is to say, okay, because we have this problem, let's start the follow-up at 3 months. And this is a form of landmark analysis. We start at 3 months, but of course, at 3 months, a lot of deaths have already happened. So what we are finding there is not going to be, neither the true absolute risk or relative risk. So it doesn't matter how we do it. This is going to be wrong. Now, notice that only in the first case we get immortal time. In the second case, it's not immortal time. We just have the bias that happens because we are excluding the first 3 months. So this is an example in which there is selection, because you can only be in the study if you have survived the first 3 months. And depending on how we handle that selection, we may end up having immortal time. So in all these cases, the assignment happened at time 0, but the eligibility when we exclude people who have not survived the first 3 months, we are moving the eligibility 3 months later, and that is the problem. That is what creates the selection. So both ways of doing this are wrong. This is selection bias. And in the first case, the selection bias creates immortal time because we start the follow-up at time 0. a causal graph for this would be like a classical graph for selection bias, in which we condition our analysis on having survived the first 3 months of follow-up. So Y3, Y is an indicator for mortality, Y3 equals 0. And because in this case we have a case in which we are conditioning on a collider, we will get bias. So this is classical selection bias. We make it into immortal time when we start the follow-up at time 0. Now, of course, this is never going to happen in a trial. People don't delete the first three months of follow-up by mistake. But this is what happens in many observational studies, in which, by definition, we restrict the analysis to people who have made it until a certain point. And then, if that happens, then we will get the same type of bias. So we have an observational study with 16 million people. Some of them start treatment at time 0, others don't start. And we have the same distribution of deaths as in the trial that I just described. Well, if this is what happens, then if we had the full data from the observational study, then we would construct the same survival curves. Everything will be the same. The analysis will be exactly the same, except if there's compounding, we also need to adjust for compounding. Here I am simplifying by saying, let's say that there is no compounding. That's not the bias I'm concerned about now. But if the investigators restrict the analysis to people who have survived for at least 3 months of follow-up, then everything that we said for the randomized trial applies now. Now we are having this selection, and there is no way of fixing it, because whether we start the follow-up at time 0, and then we have selection plus immortal time, or we start the follow-up at time 3, which we have only selection, in both cases, we will get bias. The bias is due to the selection, and the immortal time is a byproduct. It's not the reason why there is bias. It's actually a symptom that there is bias. And the causal graphs would be the same that I just described from the randomized trial. Now, rather than Z, which is the randomized assignment indicator, I have A, which is the indicator for treatment initiation at time 0. So this bias is sometimes referred to as prevalent user bias, and this bias is actually responsible for a lot of the failures of causal inference from observational data. For those of you who are familiar with the example of postmenopausal hormone therapy and coronary heart disease, this is exactly what happened there. There was the problem was not lack of randomization in the observational data. The problem was that the observational data were not being used correctly, because the analysis was implicitly conditional on having survived 1 or 2 years after initiation of hormone therapy. Okay, so this happens also in the case of hormone therapy. The bias was just selection bias. There was no immortal time, because the follow-up started after having survived for 1 or 2 years, not before that. But there are other cases. There are other published observational studies where we have the immortal time due to selection, and this happens sometimes in pregnancy studies. For example, let's say that we want to estimate the effect of vaccination during pregnancy on the risk of spontaneous abortion. And so let's say that pregnant women are vaccinated around 20 weeks, but we cannot start, we don't recruit women in our study until the second visit, and that happens 4 weeks after 20 weeks. So now we only have in our study those pregnancies that have that those women were still pregnant at 24 weeks. So all the spontaneous abortions or pregnancy losses between weeks 20 and 24 are excluded by definition. If we now start the follow-up at 20 weeks, we are creating this immortal time. And there are several examples of this that were published during the pandemic where this bias was present. So some people will say, well, wait, but this bias must be very, very easy to see because the survivor curves are flat. I mean, if we do this and you show me the survivor curves and they're flat for the first 3 months or 4 weeks or whatever, it's obvious that there is immortal time. Well, in practice, this doesn't happen for 2 reasons. One is that the duration of the immortal time may not be constant across individuals. For example, in the pregnancy study, some women may come back at 4 weeks after 20 weeks, but some women maybe 1 week or 2 weeks or 3 weeks or 6 weeks. So there is a varying length of immortal time for each individual in the study, and that means that we don't see that the survivor curves are flat. There is bias, but we don't see it as clearly. And 2, the second reason why we don't see it is because in most observational studies, the survivor curves are not shown. We just see some hazard ratio. Data are fed we feed a Cox model or something and get an average hazard ratio of the follow-up, and then we don't see the bias, which is a reason why we should always provide absolute risks, because then absolute risk over time, or the survivor curves, 1 minus the risk, because then we can see what is happening during the follow-up. Hazard ratios are a fantastic way to hide any problems that we may have. So yeah, so that is why hazard ratios, it is one of the reasons why hazard ratios are not a very good effect measure when we are making causal inferences, because if you think about that, because the hazard ratio is not constant during the follow-up, there is a time varying hazard ratio in virtually every study. The effect of treatment is not the same as every single time. Plus there is selection happening, so the hazard ratio is time varying. When we say that we are estimating the hazard ratio, well, there is no such thing as the hazard ratio. What we call the hazard ratio from a Cox model is a weighted average of the time varying hazard ratios. So it's a quantity that is very hard to interpret, because if the hazard ratio is 1 for the first few months because there is no effect of treatment, and then the hazard ratio is 0.7, and we provide the hazard ratio, we're giving 0.9, but that's an average of the effect in the first few months and the effects later. Is not a very natural way of quantifying causal effects. It's much more informative to give the survivor curves and the risk ratio at different times doing that. So how do we solve this problem? Well, by not selecting after time 0. That's the way to do it. Once we decide what our time 0 is and when treatment starts, then we cannot select people based on things that happen after time 0, like having survived for 3 months, say. So except in some cases where it may be justified, which has to be justified on a case-by-case basis, if we think that the magnitude of the effect is so big that this doesn't matter, or there is no effect in the first 3 months or something like that. But generally, the rule is do not apply eligibility criteria after the start of follow-up, which is the same thing that we know for trials, right? We don't adjust for post-randomization variables. Okay, so that's one type of immortal time. The other type of immortal time is due to misclassification, and this is the immortal time that happens when the treatment group to which each person belongs is assigned after the start of follow-up, as opposed to at the start of follow-up. I mean, this could happen in randomized trials under weird circumstances, but it's much more common in observational studies. So again, let me give you an example, and let me start with a with a randomized trial. The problem here is that the assignment to a treatment group is done after time zero, not the eligibility criteria, but the assignment. Okay, so if you think about the causal questions that we may want to ask, the type of treatment strategies that we may want to compare, some are point interventions, as I said before. So these are the interventions that happen only at the start of follow-up. At the start of follow-up, I give a vaccine or I don't give a vaccine, and that's it. But most of the questions that we ask are about treatment strategies that are sustained during the follow-up. So I give aspirin every day for 5 years, as opposed to giving aspirin just once, right? So most causal questions are really about strategies that are sustained over time. Therefore, we need time varying. We need data on time varying treatments and time varying confounders when we are trying to estimate these effects. Now, these strategies that are sustained over time can be classified into groups. They can be static or dynamic. Static are the ones in which everyone gets the same treatment at every time. So, for example, we say you take 150 milligrams of aspirin every day for 5 years. So everyone in that group at time 7, they're all getting the same treatment, which is 150 milligrams of aspirin. Whereas the dynamic strategy is a strategy in which we say things like, well, yeah, take 150 milligrams of aspirin every day unless you have a stroke. If you had a stroke, then you stop taking aspirin. So now, at month 7, among the people assigned to aspirin, some are taking aspirin and some are not taking aspirin, because those who had a stroke are not taking aspirin. That's a dynamic strategy, which is most of the questions that we ask are actually about dynamic strategies. We have very little interest in knowing what happens if someone is forced to take 150 milligrams of aspirin for 5 years, even if they have a stroke. Right? We really want to know what happens if you take 150 milligrams of aspirin over 5 years, unless you have a stroke. And the optimal strategy is a dynamic strategy. Okay. Now, that's one possible classification of sustained strategies, static and dynamic, that you may have seen before. But let me give you another classification, which is strategies that are distinguishable at time 0 and those that are not distinguishable at time 0. And I'm going to explain now what I mean by this. The point is that the immortal time happens when the strategies are not distinguishable at time 0. So when we have a target trial in which the strategies cannot be distinguished at time 0 by looking at the data, the use of observational data to emulate that target trial has led, in many cases, to immortal time due to misclassification of the assignment. So let me give you an example of a strategy that is distinguishable at time 0, which is what we just saw. Start treatment immediately after assignment versus do not start treatment. Okay, if this is what we are, this is the comparison, and we have in a trial with full adherence. Now let's say that in that trial the investigators deleted by accident. They deleted the treatment assignment indicator Z. And we look at the data and say, oh, we have lost the assignment indicator. Can we infer which group each person was in? And the answer is yes, because, well, we just look at the treatment that they actually took, let's call it A. We have that data, and someone had treatment at time 0. Okay, that person was assigned to immediate initiation of treatment. Another person didn't have treatment at time 0. Okay, that person was assigned to no initiation of treatment. So losing the assignment indicator is not a big problem if we have data on the actual treatment that people took. The reason I'm using this example is because in observational data, we don't have an assignment indicator. We only have the data on the treatment that people actually took. Now, let's think about a randomized trial with different treatment strategies. A randomized trial in which the treatment strategies now are start treatment within 3 months versus do not start treatment. Okay? As opposed to the previous trial in which the treatment strategy was start treatment immediately versus do not start treatment. So now, because we're assigning people to starting treatment within 3 months, if we lose the assignment indicator, we have a problem. Because now we see someone who is not starting treatment at time 0. Was that person assigned to starting treatment within 3 months or to do not start treatment? Because that person who did not start treatment at time 0 could have been fully adherent to either strategy. This is an example of 2 strategies that are not distinguishable at time 0. Because just by looking at the treatment that people took at time 0, we cannot know whether they were Z1 or Z0. They have treatment A equal to 0 at time 0, but that works with both. And this is where the problem happens, when we are comparing treatment strategies that are not distinguishable at time 0. Let me give you an example. Let's say that we have a randomized trial with full adherence and analysis to follow up. We have 8 million people in each arm. Here I am representing people with these horizontal lines, red for the Z equals 1 group and 0 for the Z, and black for the Z equals 0 group. Each line represents a million people with the same data. Okay, so you see here that in the treatment group, where people are assigned to start treatment within 3 months, let's say that they all start at 3 months. They start at 3 months. That means that, as you can see here, they are in the red group because they're in Z1, but the needle here marks that at 3 months is when they all start. So they're all adhering to the strategy they were assigned to. But they didn't get any treatment in the first 3 months. Okay. In fact, 2 people died. These solid circles here mean that they died. 2 people died out of the 8 in the first 3 months before they got any treatment. Now, if you look at the no treatment group, the black lines, there is no treatment here, and you see that also 2 people died in the first 3 months, and then another person died later. So, if we had this data from the trial, the analysis would be very simple. We just compare the risk of death among those in the Z1 group versus the risk of death versus in those in the Z0 group. So there will be 3 deaths in the Z1 group and 3 deaths in the 0 group at the same time. So we will say that there is no effect of starting treatment within 3 months versus not starting treatment. Okay, and this is how the survivor curves would look like for this trial. So they are fully overlapping from the red and the black. There is no difference between both groups. Now let's say that the investigators deleted information about Z. They don't know now. They don't know the treatment strategy each person was assigned to. Now that is a problem, because see, of those people in the Z equals 1 group, you see 2 of them died before getting treatment. So if we look at the data and assigned to a treatment group, those who eventually got treatment, then those 2 deaths are not going to be counted in the treatment group. They are going to be counted in no treatment group. So treatment is going to look much better because fewer people died under what we're doing, right? So we have to be very careful, because now we'll know who is red and who's black. We have data on observed treatment, but not the assignment Z. Which means that, as I said, if we say, okay, anyone who didn't get treatment is black, and everyone who got treatment is red, we have a problem, because now we're putting those two red deaths into the black group, and that is a misclassification of the assignment. Those two deaths that are in the that are removed should have remained in the red group, but we have no way of knowing that of where they were because we lost information on Z. Okay, what happens now? Now we have a bias. We have a bias because everyone now in this redefined red group is immortal for the first 3 months, or for the time between assignment and when they get treatment. They cannot die now, because if they have died, we have put them in the black group. So this misclassification generates immortal time. Again, this is not a selection problem like before. This is misclassification of the assignment. And this is going to create bias in all of our estimates. In fact, if you look at the survival curves, now they don't look overlapping. We are loading the no treatment group with deaths that should not be there. So we have now bias. Okay, and this can be represented using a causal graph by something like this, in which we will have now a new assignment indicator Z star that we have created, but is not valid because it's based on whether you survive until you get treatment or not. Now, the way that people have dealt with this in the literature is by thinking about this in terms of person time. So let's just use all the person months that were not treated and the person months that were treated. And let's compare those person months now with a hazard ratio. This is not a good solution to the problem. It does eliminate the immortal time, but now the treated are started at a different time than the untreated. There is already some selection going on. So we are estimating the rate in a selected group of survivors in one group versus the other. So this doesn't give us the same thing that we would have had in the trial if we had known the assignment indicator. It's a different type of bias. It's not immortal time. No. So what can we do that is valid? One possibility is to change the question. So rather than asking the question, what is the effect of starting treatment? What is the effect of starting treatment within 3 months versus never starting treatment? Well, we can change the question. So what is the effect of starting treatment now versus not starting treatment? And that means that we move time 0 to the time when treatment is initiated. So that is one way of dealing with this. We start the follow-up at the time of initiation. But this may not be the question that we want to ask. We may want to ask the question, what is the effect of starting treatment within 3 months? Because in practice, in the real world, we're not going to be able to assign people to immediate initiation of treatment. There will be some grace period for treatment initiation, and we want to incorporate that grace period into our question. So what we can do here is this, we can use a 3-step approach that has cloning, censoring, and weighting that solves this problem. So let me quickly show you how this could be done if we wanted to compare the effect of different durations of treatment. So the treatment strategies that we are comparing now are treatment strategies that are defined by the duration of treatment. So using aspirin for 0 years, for 1 year, or for 2 years, okay? Of course, we cannot go to the data and find people who have used aspirin for 2 years and compare them with those who have used aspirin for 0 years. That would be biased. That is where immortal time happens. And this is one of the most common questions that you can ask in research is, what is the effect of duration of treatment? But we cannot compare people who have treatment for 2 years versus people who have treatment for 0 years, because that is exactly the problem that we've described here. So that type of naive comparison is it's going to result in Immortal time and bias. So let's say that we have a randomized trial with three groups, 0 years of aspirin, 1 year of aspirin, 2 years of aspirin, with perfect adherence and no losses to follow up and millions of people, so we don't have to worry about our random variability for now. And this is the data from my trial. So I have 12 million people. Each row is 1 million people with the same data. We have, for each person, we have the assignment, Z, with here I'm calling it dur A, is the duration of treatment they were assigned to. So they, you see the first 4 people were assigned to 0 years of aspirin, the next 4 people to 1 year of aspirin, and the last 4 people to 2 years of aspirin. And everyone did what they were assigned to. So person 1 was assigned to 0 years of aspirin, and you can see as aspirin 0 at time 0, A sub 0 is that's aspirin at time 0 during the first year, and then A sub 1 is aspirin during the first year. It was also 0. This person didn't die. You look, for example, at person 10. That person was assigned to 2 years of aspirin and had 1 for treatment during the first year and 1 for treatment during the second year. So everyone is doing what they were assigned to. If I ask you how to analyze the data from this trial to estimate the effect of aspirin, is trivial. We just compare the risk of death after 2 years in each of the groups. So if we want to compare a duration of 2 years versus a duration of 0 years, then we just compare the risk of death after 2 years in the last 4 people with the risk of death after 2 years in the first 4 people, right? And because you can see here that 3 people out of 4 died in each of those groups. So you look at the first 4 rows, 3 people have died by the end of follow-up. If you look at the last 4 rows, 3 people have died at the end of follow-up. So the risk is 3/4 in each of those 2 groups, and the risk ratio is 1. There is no effect of duration of treatment. So it doesn't matter whether you use aspirin for 2 years or for 0 years. That's nothing. Now, this is a very oversimplified example. I'm not making a distinction between the intention to treat effect and the per protocol effect because everyone is adhering. Okay, now let's say that someone says, well, but I actually don't like this because, you know, if I look at person 12, well, person 12, we assigned that person to 2 years of aspirin, but she only took 1 because that person died after 1 year, so never got to take the second year of aspirin. So I don't want to include that person in 2 years of in the 2 years of aspirin group. So if we do that, if we exclude those people, then we are going to get biased because we are going to find that there are only 2 people left in that group, person 9 and person 10. And of those, 1 dies and the other doesn't die by 2 years of follow-up. So that is going to look like 2 years of aspirin is much better than 1 year of aspirin. That's immortal time. Of course, it's better because we are excluding people who died in the first year, right? So we will never do this with the data from a randomized trial. Unfortunately, it's done with data from observational studies often. Okay, so let's say now that we have data from an observational study, and the data that we have from the observational study is exactly the same as the data from the trial that I just described. It's exactly the same data. To keep it simple, there's no confounding. We don't have to worry about confounding here. There's nothing to adjust for. The key difference between an observational study and a randomized trial is that in the observational study, we don't have the assignment indicator. This column, dur A, we don't have it. We don't know which treatment people were assigned at baseline. In fact, they might not have been assigned to anything. They just take treatment when they take treatment, or they don't take treatment when they take treatment. So we may have the same 12 people, but we don't know their treatment group. The treatment strategy they were assigned to. That's a problem because the strategies are not distinguishable at baseline. The strategy 1 year of aspirin and the strategy 2 years of aspirin, at baseline, they both have aspirin. So we don't know, just by looking at the baseline data, which strategy these people were assigned to, and we cannot look at data in the future because that will create immortal time. So what we have to do is to create our own assignment indicator. We have to create that column, dur A, that we don't have. Okay, so you see the questions marks there. We don't know which one is that. Okay, let's just create it. So we can look at person one. So person one at time 0 has treatment 0. Okay, so that person was assigned to 0 years of aspirin. That's easy. And the same for person 2, person 3, and person 4. They were all assigned to 0 years of aspirin. The problem now, you see person 5, we don't know if that person was assigned to 1 year of aspirin or 2 years of aspirin. All we see is that that person had treatment at baseline. So what do? We create 2 clones of person 5, person 5A and person 5B. Person 5A is assigned to 1 year of aspirin, person 5B is assigned to 2 years of aspirin. And we do that with every person from 5 to 12. We don't know which strategy, whether they were assigned to 1 year or 2 years, fine, we assign them to both. We clone, and now we don't have immortal time. So cloning gets rid of the immortal time. But we pay a price. The price that we pay is that now, well, we have the same people in both strategies. Persons 5A to 12A are the same as person 5B to 12B, and they're both strategies. So we will always find that there is no difference between those 2 strategies. It's like if we're doing an intention to treat analysis with extreme non-compliance. So what we do then is to censor clones when they deviate from the strategy they were assigned to. So you see, for example, person 5 assigned 5A assigned to strategy 1 took treatment only 1 during the first year, so that's fine. But person 9A was assigned to 1 year of treatment, and this person took treatment also in year 2, so we censor that person because he's deviating from the strategy. So cloning eliminates the immortal time. Censoring allows us to compare both strategies, but we pay a price. The price we're paying is that now there is selection bias due to censoring, and that creates bias. So we need to eliminate that selection bias, and we do that by inverse probability weighting. So the last step is to weight the uncensored people here. And after inverse probability weighting, then we will get, again, we are weighting people by the inverse of the probability of being uncensored in its group. And after doing that, then we can do the analysis again, and we get our estimate without bias. So we do cloning, censoring, and weighting. Cloning to eliminate the immortal time, censoring to eliminate the non-adherence, and weighting to adjust for the bias that is created by censoring. Of course, in practice, we also need to adjust for compounding. Technically, we don't need to do the cloning. Rather than the cloning, we could assign people at random to one of the strategies with which their data are compatible with at baseline. We could do that, but it's very inefficient from a statistical point of view. In fact, we did that in one example here, in which we did the same analysis with cloning, and this is the hazard ratio here is 0.78, and that's the confidence interval. And then if we don't do cloning, if we just assign people at random, we did that 100 times, and each of those horizontal lines there is the hazard ratio that you will get by assigning people at random. You see, it's very, very unstable. If we take the average of all those 100 lines, we get 0.79, which is the same thing that we get with cloning. So cloning is just a trick to decrease the variance of the estimate, but it's optional. We don't have to do it if we don't want. If we have lots of data, we could assign people at random. And then the other way of doing this is by using the G formula. That's also an alternative to cloning censoring and weighting. Okay, so I'm going to finish here. There is no such thing as immortal time bias. Immortal time bias is just something that happens when there is selection bias or misclassification bias. Selection because we are using eligibility criteria after the start of follow-up, or misclassification bias because we are assigning people to treatment based on information that is not available at the start of follow-up. If we do target trial emulation, we eliminate this type of design bias, but we have to use cloning, censoring, weighting in case that we want to do that. And I'm going to finish here because I think that we are at time. I don't know if we have time for questions.
Great, thank you so much. This is very, very interesting. Thank you for this fascinating talk. So yeah, just want to open it up to any questions. I saw that there was one question, but it looks like that was actually, yeah, that's right, was actually answered in the talk. Yeah, just want to open up if there are any other questions. You can type them into the chat if you'd like, or you can ask directly. So maybe I can get started with a question here then. So so as you kind of say on this last slide, so it doesn't eliminate data biases, but it does eliminate design biases. And so in terms of kind of when they're kind of combining this kind of cloning and or like the inverse probability weighting type things with if there's measurement error also in kind of the in kind of the time censoring records, like can you handle that in straightforward ways as well, or
if there are other types of biases, be it confounding or measurement error or something like that, yes, we need to deal with that in some way, or we get bias. Here I was focusing on how to deal with the immortal time, but everything else that you know about how to deal with confounding or with measurement error, all of that needs to be added. Those are extra layers here.
Are there any other questions from the audience? Okay, if there are no other questions, then maybe we can thank Professor Hernán again, and yeah, thank you.
I had a question. Yeah, thank you for a great talk. I'm Sahar Zangina. I'm at RTI International, a senior researcher there. I was wondering, because the whole idea of cloning was kind of new, and I was wondering if you could kind of elaborate how it's related to the more traditional structure of like counterfactual outcomes and imputing the counterfactuals, and how it's similar and how it's different.
Causal inference is always about imputing counterfactuals. It's the only way in which we can do it. It comes under different names, and I may give a whole talk like here without talking about that, but that's exactly what I'm doing. That's the only way. So here, if you think about the concept of target trial emulation, is just another way of saying we are imputing the counterfactors. We are emulating a randomized experiment which people were trying to emulate a randomized experiment which people are assigned to one arm or the other, so that the observed outcomes under each arm can be used to estimate the counterfactual outcomes if everyone had been in that arm. So that's really what we're doing. Cloning is just a statistical trick, really. We don't know which strategy people were assigned to, because the strategies cannot be distinguished at the baseline. So one simple option would be to say, okay, let's assign them at random. So we would analyze our observational data by saying, for each person, in the case of the aspirin example, each person that start aspirin at baseline, I don't know if that's 1 year or 2 years, so I'm going to flip a coin for each person. So we physically randomize in an observational study each person to either 1 year of aspirin or 2 years of aspirin. That would be the easiest way of doing it. The problem with that way of doing it is that you will have very wide confidence intervals that I showed here in this thing. So rather than doing that, which is what we did in these 100 lines, is rather than randomizing each person to one strategy or the other, we just copy the person. I mean, we just put two people there as if they were two people, and that makes a more effective use of the data that we have. And that is what cloning is. But it's just a statistical trick to be able to use all the data that we have. We never, because one of the clones will always be used, as opposed to if we randomly assign people to one strategy of the other, and if someone who is actually using 1 year is assigned to 2 years, that person will be censored after 1 year, and we're losing all the data that comes after that. But if we have clones, one of the clones will be censored, but the other clone will not be censored. So we're using all the data that we have. But that's just a trick to use all the information in the data. We are always trying to estimate the counterfactual risks.
Thank you. Great talk.
Great. Well, thank you so much, Professor Hernán. And we will now take a little bit of a break and come back, I believe, at 3 Eastern. Is that?
Thank you.
Thank you so much.